Our next presentation is by Scott Elton. He's a professor of neurosurgery and division chief of pediatric neurosurgery here at UNC Chapel Hill. He's board certified. He specializes in craniofacial disorders, Gowry malformations, concerning brain and spinal cord tumors. He's currently the UNC Children's Hospital operating room director. Scott, it's my pleasure to have you talk on hydrocephalus evaluation and management in the MPS population, but it can even be in general. Thank you very much for coming.
Yeah, thanks for the invite. I really enjoy doing this when I get the opportunity, and so I look forward to hearing some information here today. So
Uh,
let me share
share
my
a slide.
presentation here. All right, hopefully that is visible to everybody.
I think it is. So,
All right, all right. So is going to be a lot of show and tell, and will probably be more information than you ever wanted to know on the evaluation and management of hydrocephalus. Specifically, no disclosures here, and no conflict of interest either. Um, Very briefly going to touch on the pathophysiology of hydrocephalus and a little bit in general term, but as far as MPS goes, and then I really want to get into the meat of this, which is how do we evaluate, how do we manage hydrocephalus in the MPS population, and this is can be broadened out to other children with hydrocephalus. So hydrocephalus and MPS, the one common themology about hydrocephalus and MPS is that it is very poorly understood. I mean, there's a lot of work going on to try and understand the brain pathophysiology that leads to hydrocephalus. The incidence is not well known. You recognize it when you recognize it, but you don't recognize it when you don't. And so trying to sort out who has and who doesn't have hydrocephalus can be a challenge. This can occur with all types of MPS. It's not particular to one or another of the categories. Again, the pathophysiology really is not well understood. The one thing, of course, that's common is the glycosaminoglycan accumulation in tissues. So things like the meninges, the dura, the arachnoid will thicken and obliterate spinal fluid pathways. The arachnoid granulations, by which CSF is reabsorbed into the vascular system, can also become thick. These act like little one-way valves, and so as they thicken, they're less effective. The skull base, again, because of some of the cranial anomalies, can compress the venous system, which can also raise back pressure in the brain, and then direct brain involvement as well, although it's unclear exactly how this impacts the production of hydrocephalus. So it's pretty clear a lot more basic science work needs to be done to evaluate the reasons for hydrocephalus in these groups. So, getting into the discussion of hydrocephalus, it's important to keep in mind the definitions, and there's going to be scattered takeaways here. And this is one that you should take away: that hydrocephalus is a clinical definition. It's really based on the signs and symptoms of elevated intracranial pressure. These can be acute, in which people are quite sick immediately, or more chronic, which tends to be more the MPS population. It's unusual to see acutely elevated pressure in this group. When you look at the imaging side of things, whether it's CT scan, MRI, ultrasound, ventriculomegaly is the imaging definition. Hydrocephalus is not an imaging definition, and often in reports, there will be a report saying, this MRI is consistent with hydrocephalus, or ventricular size is consistent with hydrocephalus. That's not accurate, and so just keep that in mind. Again, this is hydrocephalus is a clinical diagnosis. So just again, looking at a couple of scans side by side, these are CT scans, and for folks that may not look at these regularly, the forehead is at the top of the pictures, and we're looking at the ventricles inside the brain. And so these are pretty big ventricles; they're quite large. Read as hydrocephalus, this is actually a normal kid. And then over here on the left, we've got very tiny ventricles, but this is actually hydrocephalus. So the imaging is only supportive of the clinical view. A lot of models. Not going to make this or belabor this point, but we still have a long way to go in understanding hydrocephalus. And then when you add the overlay of a process such as the MPS diagnoses, it gets even more complex. And we don't have good models. If we had good models, our treatments would likely be better. We still break hydrocephalus into two basic groups. So one of those groups is obstructive hydrocephalus. And I put the picture of the dam up here because that's very much what we think of with obstructive hydrocephalus. There's a dam or a block in the normal CSF pathways. Absorption is usually fine. And then you get this blockage essentially that causes the ventricles in the brain to expand. This is pretty uncommon in MPS and is likely only seen in situations where there's some adjacent anatomic abnormality that would produce this type of hydrocephalus. The more common, particularly in MPS and other groups of hydrocephalus, is what we call communicating. So much like the kayaker in the flooded road here, the fluid can flow. The spinal fluid clearly can make it through the ventricular system, but it just can't be absorbed. So everything backs up. So you can have mixed types, certainly, the obstructive and the communicating, but the communicating is really just a failure of the pathways to reabsorb CSF, and that goes back to what I was saying on the earlier slide, and that all of the elements through which spinal fluid flows in order to get back into the venous system are thickened and essentially act as an obstruction to reabsorption. So how do we think about this? How do we evaluate it? And it's really the three tenets here: clinical, imaging, and invasive. I put this up not because this is an MPS child, but this is what severe chronic hydrocephalus looks like. It's still a terrible disease around the world. Um, Acute hydrocephalus, which again is not really part of the MPS group, but is important to understand, especially if you have an MPS child who may have been shunted, is where they'll have headache, quite frankly, severe headache. They may not be able to voice that, but it's severe irritability. They'll often have vomiting, which is described as projectile. They'll have sunsetting eyes, as you can see here. It looks like the pupils are falling below the horizon or the lower lid. And so those are all signs of very high pressure. And this can be fatal if it's not quickly addressed. Chronic hydrocephalus, an example of which is here, is where often development is normal to delayed in whichever population you're looking at, and more than what would be considered the standard. Usually, the ventricles are quite large in the head. Frequently, the head circumference chart shows very rapid rise in head circumference over a very short period of time, weeks into very short months. And these kids gradually will fall behind. They don't tend to develop acute hydrocephalus except in unusual circumstances. And the way to think about this is the brain is just kind of winding down. It just can't cope with this pressure. So again, chronic hydrocephalus, again, think clinical, don't think imaging. This actually is a scan of a child with MPS, and it's a pretty normal scan. There's not a whole lot on here that says that there's hydrocephalus, and there shouldn't be, because we're really thinking about the clinical, like what does this child look like? But it is definitely more challenging in this group to sort out who has just plain macrocephaly and developmental delay versus progressive hydrocephalus and subsequent macrocephaly and developmental delay. So diagnostically, we have the same technologies we've had for a long time. CT scan is a very nice, very fast way to look at the head, and we'll do a scan of the brain in just a matter of a few seconds. At UNC, like a lot of children's hospitals, we use these ALARA protocols. They really reduce the radiation exposure. However, there is still a significant exposure on any given CT. The estimated number of chest X-rays, imagine getting all at one time, is about 100. So So we've really tried to supplant the CT scanner with the MRI scanner. The computing technology and just in general MRI design have really evolved over the years, that we can get these fast sequence or fast MRI or rapid sequence MRIs. And frequently this can be done without sedation, although it's really child to child specific as to who would benefit from sedation for images. These sequences take a matter of seconds to just a few minutes to acquire. The image quality is good, but not great. And you do have the element of the MRI and the safety required around the MRI. But in general, sedation can be avoided to get brain imaging. And there's particularly and importantly, no radiation with the MRI. I put this up just to show sort of contemporary imaging techniques side by side with the ultrasound, of course, on the left and the MRI on the right. And you can see there's pretty comparable information on each of the scans. But the beauty of MRI is beyond no radiation is we can really get good multi-plane imaging. So however we want to look at the brain from the side, from the front, from the top, we really can look from all angles with that, which the other technologies can do, but have some limitations in the ability to acquire those images. So again, we look at ventriculomegaly in the MPS group, and we say, okay, is this, is the brain atrophic? Is the brain, shrunken relative to what it should be, and as a result, the ventricles are bigger because there's more room. What we call an ex vacuo phenomenon, or is there truly pressure here? Is there really really pressure that is just not being reflected in the imaging, and we're challenged to sort that out with the child in front of us. So then you can move from imaging, clinical imaging, to the invasive technologies. And so obviously escalation of risk with this. So lumbar puncture is great in a lot of ways. It's pretty straightforward to do until you have to do a bunch of these, or you've got a child whose anatomy may be challenging. Um, there, um, there are questions about it as a proxy for intracranial pressure, for elevated intracranial pressure, in that you're collecting out of the lumbar cistern, and often people are either curled up pretty tightly, they may be sitting and leaning forward, they're often under sedation, and so it's unclear exactly what the relationship of the pressures recorded in the lumbar spine are to the brain pressures. But if no other way to get at pressures exists, then this is a really reasonable way to go ahead and try and sort out what's going on with pressure. Other ways that we can monitor pressure are an external ventricular drain, EVD, or ventriculostomy is sort of a common terminology for that. And that's demonstrated by the top right picture, where you've got this tube coming out of the head. In the cartoon, that would be on the left side of that image, the tube going into the ventricle itself. We do have other monitors that go in the brain substance, and as you can see, this child down here who is wide awake and trying to smile, these can be really helpful in the awake patient, in just terms of understanding while they're hanging out in bed. Cables are short on these, you can't really go for a walk. Is okay, what does real-time brain pressure look like while they're watching TV, eating dinner, those kind of things? It gives us really good trended data. It's also less risk than putting in a ventriculostomy. The ventriculostomy is considered the gold standard because you're going directly to the ventricles, but the others are a very, very close proxy second. So the MPS group, like a lot of children, how do you keep them in bed? How do you keep them from, trying to disconnect the device or pull it out, quite frankly? We've got lots of tricks. The pediatric intensive care docs are great at trying to manage this and make sure kids are going to be safe. But there is no question there's a challenge with this, with this and other groups. We don't know what normal central nervous system pressure is. We generally say 0 to 25 centimeters of water or millimeters of mercury. But with large ventricles, okay, what's normal? So the NPH, normal pressure hydrocephalus, is a diagnosis that occurs mostly in the elderly, and it consists of essentially large ventricles and some clinical findings that lead you to the diagnosis. When you actually measure the pressure in the NPH group, their pressures aren't that high. And so they may have already passed the point at which they had high pressure, everything expanded, and now it takes very low pressure to keep things open, but you really are somewhere on the hydrocephalus curve. And so the same thing, in the current group is, when you're looking at the MPS group, is similar problem, right? Is if you do a tap, if you do brain pressure monitoring, what what's normal, and we just don't know. One of the things that's done in the NPH group is what's called a high volume spinal fluid tap. So these patients will often get a very, very high volume CSF spinal tap, and then some assessment in the next day, the day after, to see if they've improved. There's really nothing similar in the MPS group as far as trials go for this, for removing high volume of CSF. And so it would remain to be seen if this would actually be an assessment for this group to determine if they truly have hydrocephalus. Okay, moving from evaluation to management. So things are old. Things do not change much, and so many of the things that I'm going to talk about have been around for quite some time. So medical management generally has limited utility. If you think somebody has elevated pressure, Diamox can be given. It's actually a pretty well tolerated oral medication. It can be given IV if needed, and has chronic kidney effects. There's reasons not to be on it if you can avoid it for the very long term, but can be a nice adjunct if you've got somebody with hydrocephalus and you just want to manage symptoms with medication. Other diuretics have been used, the idea being that if you diurese the patient, then you're going to also diurese the brain, remove some fluid from the brain, take down pressure in the brain. They're less effective. There are other things that have been tried or promoted over the last several decades, but really with no beneficial effect. One thing we use in acute elevation of pressure is hypertonic saline solutions, but those are really administered for folks who have tremendously high pressures, acute pressure, not typically the MPS group, and really need to be given in an ICU setting. All right, shunting. So this is still generally the workhorse of pediatric neurosurgery, and at its core, it's actually a lot simpler than folks make it out to be. It's really just a method to bypass the normal CSF pathways. So going back to those two models, obstructive and communicating hydrocephalus, either type, you just need to get that trapped fluid out of the brain so you can get brain pressures down. And so that's essentially all a shunt really is. Every modality that we do can be described as a shunt, even some of the ones that don't leave tubing behind. And it's probably the best way to treat the MPS group since they have communicating hydrocephalus and we're not so concerned about trying to reopen or bypass obstructed pathways. I bring this up just again, it's always fun to look back at some of the history of where we've all been. And so shunt valves, were introduced before the turn of the 1900s, which is hard to imagine. The first actual shunt valve was created in 1949. And then in 1960, silicone was introduced, which actually changed everything about shunt design. John Holter, who was an engineer and watchmaker by trade, who's pictured here looking at a shunt design, If you look to the right, his wife is holding their daughter who has hydrocephalus again, has this very large head, and he really wanted to come up with a better way to treat hydrocephalus. Unfortunately, his shunt design wasn't completed before his daughter passed with her hydrocephalus. So John Holter came up with really the very first practical valve that was put in for the better part of 30 to 40 years to treat hydrocephalus, a very successful valve design. All subsequent valves are based on some variation of John Holter's valve. So the different types of shunts we have, there's fixed pressure, and then we have these programmable or adjustable shunts. So pressure regulated valves are actually pretty simple. This is just one example of pressure curves on the right. You can pick a 1.0 or a 2.0 and know how much flow is going to go through the shunt valve. These really work like a radiator blow-off valve. So as pressure in the brain goes up, the shunt valve opens more fluid flows through. As the pressure comes down, less fluid flows through. So they really do help regulate the amount of flow of spinal fluid out of the brain. There's all kinds of styles of these, and these are just some examples of that. And so these really come down to the people that put them in and where they get put in, and there's not really a benefit of one over the other. So fixed pressure valves have an issue in that they will continue to flow regardless. So if you put say a medium pressure valve in, it'll continue to drain at medium pressure. But if you need higher or lower pressure because you're over or under draining, then you've got to go back to the operating room. You've got to remove that shunt valve and put in a new one. So obviously you're exposing these children to more anesthesia, more surgery, and more risk. So people came up with these programmable shunts or adjustable shunts, thinking that if we can just adjust, we don't need to go back to the operating room. We can just do this in the office. And so these are pretty straightforward devices that we can literally readjust in the office. They're probably not good for everybody. There's probably select groups, but in kids who have challenging hydrocephalus, too much drainage, not enough drainage, this actually is a really good option to control that drainage just in the outpatient setting. Again, this is there's a whole bunch of these. This is something called the Medtronic Strata. These valves, however, have their own issues. So it's really unclear how much to adjust these when somebody comes in. If you have a child who you put a shunt in and now maybe they are saying they've got headaches, well, do they have high pressure, low pressure? So adjusting is a little bit of a best guess game. They also, at least some of the valve designs can change in a magnetic field. And of course, we try to get MRIs when we're following up with hydrocephalus. More new generation valves actually can lock and so are much safer for MRI, especially if you've got kids getting MRIs that are not at the children's hospital or not near a pediatric neurosurgeon or office that can check the valve after the MRI. Again, this is just yet another example of a programmable valve. Shunt issues, so shunts in general, infection is their most common problem, averaging 1 to 5% in cases. It's highest in the first month, and then after 6 months, infection is extremely rare. If there are other concurrent lines or tubes, the risk of infection is much higher. Shunt failure can be up to 50% at 5 years from implantation, but by and large, in the MPS population, that's not very common. When you look over a lifetime of shunts, how often are these going to be revised if you average it out? And it works out to about once every 10 years, but you may have a number of shunt revisions in a very short period of time and then no more. You may put one shunt in, the first shunt you put in, and never touch it again. So there, we always talk about this once per decade revision rate, but it really varies widely. Okay. I show this as an example of something we don't see, thank goodness, much anymore. This is what I call the space shuttle of shunts. This is in children who end up with, or can end up with what we call loculated hydrocephalus, where the ventricles are trapped due to scar tissue. And so you may need more than one catheter. There are many ways we've come up with to avoid doing this going into the future. And so one of those ways is to add something called endoscopy into our regimen. And so endoscopy, neuroendoscopy, is really just the variation on laparoscopy or arthroscopy with smaller scopes. We've got steerable scopes, as you can see in the bottom right. We've got these rigid glass rod scopes, as you can see in the middle. And these have been, again, much like shunts, these have been around for a while. These are not new devices. We've got all kinds of tools we can put through these. So we can actually look inside the brain and work in pretty tiny spaces. Most of this is good for obstructive hydrocephalus. So again, would be a rarity to see this for a child with MPS and hydrocephalus. We have endoscopes that are small enough to go through a shunt catheter. The image on the right, the white with the little holes is the shunt catheter, and you can see at the very tip there's this little black line, which is the tip of the endoscope, and the light that is at the end. So we can actually look down through shunt catheters if catheters are stuck, if we need to try and position them. So we have some pretty effective tools to look inside the brain in kids with hydrocephalus. Neuroendoscopy, again, not new. It's been around at least since 1910, but really picked up in the modern era. In the old days, they used to do a lot of these obstructive surgeries, like the picture on the left, where it was more formal brain surgery. Scans in these kids, again, not so much in the MPS group, but these kids that you do the endoscopy in tend to have ventricles bigger than average, so that can be a confounder when they're being evaluated. So, okay, we have a kid comes in and there's a question of the shunt. Is it working or not? Again, clinical imaging and invasive, those are the ways that we look at these. So what is shunt failure? The shunt's failed. Whatever the way you've got to divert fluid is no longer allowing that drainage. And so we're back to the original problem. And that in a shunt can be due to device problems, fracture, obstruction, dislodgement, or infection. Again, we look clinically. This is the second big takeaway. Mother knows best. It's not the shunt. This happened before. They're not acting right, and it shows in their eyes. This actually passes the scientific scrutiny test, and at least 2 studies out there show that this single statement, in terms of the family understanding if their child is in shunt failure, is about 80% accurate. So if mom comes in saying this looks like the shunt, it looks like what happened before with the shunt, definitely worth paying attention to. When shunts fail, they usually fail the same way every single time. And again, that is more into the headache and the vomiting. Shunts usually fail in short order, so you don't typically see the chronic failure findings, but the more acute ill findings. So how do we absolutely know? We really have to surgically explore the shunt if we're concerned about failure. There are some ways to try and get at function, but most of them, again, they're proxy ways, and there aren't standards for what the results are. We can do shunt taps, shunt dye injections. Again, they may help, but we just don't know what the standard is for that. The important thing to know about shunt taps, because this will sometimes come up in conversation, is, well, we've got a child with fever, they're kind of irritable, we don't know if there's a shunt infection. Well, if you're outside 6 months from the last shunt surgery, it's probably not shunt infection. It's likely to be something else. But if a shunt tap needs to be done, which is just putting a needle in the little reservoir in the shunt valve, then no reported iatrogenic shunt infections have occurred. And so there's not really a good reason to not do a shunt tap if you want to try and access fluid and measure pressure. It's important to take away that fever does not equal shunt infection. You need to have the other signs of hydrocephalus or meningitis before just assuming a fever is related to the shunt. Imaging, again, goes back to progressive ventriculomegaly, transependymal flow, which is a capping of fluid into the brain tissue itself. We'll do shunt series where we look at continuity of the shunt, and I know this doesn't reproduce very well, but we look at the head, the neck, chest, and abdomen to show that the shunt is still in continuity and not disconnected. This is just a quickie example of a CT scan. On the left, the three pictures are the working shunt where the ventricles are smaller, and on the right, with the clinical findings leading to the scan, the ventricles are much bigger. So everybody in this group is completely familiar with what I'm going to say here, which is parents talk a lot. This is super helpful when it comes to hydrocephalus. There's a number of hydrocephalus organizations. The Hydrocephalus Foundation or Hydrocephalus Association has been around for a very, very long time, at least 3 decades. And so these are other support services that we'll often share with families so that they have folks to talk to. The MPS group, again, being sort of a select group of parents, I have found to be really great in these conversations of, my child is getting a shunt, has a shunt, and I'm kind of worried about this, and I know your child does, and so sharing those stories is really helpful. But again, lots and lots of resources online for hydrocephalus. So I'm going to wind down here. That is, in a nutshell, everything a pediatric neurosurgeon knows about shunts and hydrocephalus. There's a lot of things coming to manage hydrocephalus and technologies that are pretty futuristic, but will likely revolutionize how we manage hydrocephalus. That will likely not rely on things like valves and tubing running down the body. So what's coming should be pretty fascinating. So with that, I'm going to wrap up and open it up for questions.
Thanks for really a nice, history in terms of what's going on and the needs, and also the challenges, what we don't know about hydrocephalus in MPS patients. Let's just look at the Q&A and see if we have anything. I see nothing right now. So one question is, what would you do to consider if the child has a shunt and will receive gene therapy via ICV or cisternal magna? So
yeah, great question, and a really pertinent one. This is a very similar question to what if kids are getting chemotherapy and have a shunt, intrathecal chemotherapy. So there's a shunt valve that's on the market. It's been around for a while now. That is the only valve it's adjustable valve, but we can actually shut it off. So so it's a bit of a balancing act, right? Like, you don't want to turn the shunt off for an extremely long period of time because the hydrocephalus, of course, will rear its head.
Mhm.
But around the time of injection, to have, turn it off, have the child monitored, likely in a step down or ICU setting, so we can watch things like heart rate and so forth. That's doable. Again, it would have to be some conversation about how long do we, leave this thing shut off. But if a child's a candidate for the intrathecal, then if they need a shunt, then getting one of these, this valve in. If they already have a shunt or shunt valve in, it's probably worth a conversation. If they don't have this valve that we can shut off, probably worth a conversation with the family about going back to the operating room and exchanging the valve they have for this one. It does pose, of course, the risk of going to the operating room into the shunt, but does give us the opportunity to turn it off for at least a little while to allow the medication to circulate.
What's a little while to you? A few hours,
Yeah,
half a day, a day?
child dependent. Let's say that. Yeah, it's a really good question, right? There are some kids where you'll turn the shunt off and they'll start throwing up within the hour. There are kids who you'll turn it off and 8 hours later they're sitting there happy as a lark. So you really have to base it on clinical grounds. There is another group that's sort of similar, again, a kind of select group, in the kids that get baclofen for spasticity. If they have a baclofen pump, so they're continually having infused baclofen into the subarachnoid space,
Mm.
and those kids can have shunts as well, and we don't shut those off. So it seems to be the shunt doesn't really impact much of the CSF circulation of the medication. That being said, again, if you're going to do a intraventricular injection, we'd want to figure out some way to turn off the shunt to prevent the medication from just going right out the shunt and down into the abdomen or wherever the shunt
Right.
ends.
I would expect with their communicating hydrocephalus, they won't immediately start raising their
Yeah.
intracranial pressures, but I just don't have a sense of a time frame. In
Yeah,
that,
usually not. If they've had a shunt in for a little while, then they can become sensitive to turning it off. But you're correct that there's probably some time window after turning it off.
you talk about a high volume CSF tap. What's your definition of a high volume tap for these patients?
75 mLs or better. Yeah.
For a,
Yes.
for a 2 or 3 or
Yeah.
4 year old, that much?
Yep. Yeah, there's roughly 125 to 175 mLs of CSF in the CNS, central nervous system. So yes, it is possible to take that off. The younger kids, it takes a while. Older kids, it's a little bit easier. And you just have to be patient. But yeah, you really need to take off a pretty decent volume. The idea being that you're removing the ventricular fluid and relaxing the brain. And the only way to effectively do that is to take off 50, 75, 100 mLs.
It just seems like a huge amount to me because my clinical
Yeah,
experience has been we've tapped kids to measure opening
yeah,
pressures.
mhm,
And a lot of the families will report for a day or two after just a standard LP, they'll
yeah,
be doing better and then their behaviors will come back. And even
yeah,
that's nowhere near 50 or 100. This is probably with leakage, maybe 10 or 20, even off
yeah,
taking off 5 or 10. So that's
yeah,
interesting.
yeah. You asked, so
I know.
yeah, yeah. No, it's not well studied, right? I mean, there's not. It would be a great study to do is to understand, right, in that evaluation period for that day or two afterwards, and maybe establish a standard for here's the range of what we should remove to really test these kids. So it does open itself up to that.
Have people devise shunts that actually have measurement devices within them to monitor intracranial pressures?
Yeah, good question. And no, they been a lot of conversations over the last 40 to 50 years. There's been a lot of technology showcased. That would be the holy grail of shunt management. If somebody could wand their phone over it and send you the data, they
Hmm.
come to the emergency room, we could figure out what the shunt pressures or flow or whatever for the last month. That would be incredible. Shunts are not a high overhead item for a lot of these companies, even though hydrocephalus across the world is an issue, and it's not very sexy. So the R&D for monitoring, it's there, but it just if companies aren't going to do well by selling those things, they're just not going to get them to the market.
And that's unfortunate. It's clearly, as you appreciate more than I do, it's really needed.
Mhm. Yeah, yeah.
I'm not sure how many shunted, how many MPS patients here, but I know in the literature and I've seen in the past that subdural hematomas can be an issue of a complication of a shunting a MPS patient who basically has very large ventricular system
Mhm.
because of that rapid. What would you consider in terms of the pressure setting, or how would you set that pressure sensitive valve initially, and would you change it with time?
Yeah, so yeah, really good questions. So this is the group, and I alluded a little bit to this, that
Right.
probably you need to put a programmable shunt in, and you need to start it out at the highest or a high setting, and then over time dial it down. There's a range on these to somewhere in the middle of the range, so you can go up or down as you need to. And so that really is the best way to try and avoid subdural formation. These, of course, these kids' brains can be a little bit stiff, so when the ventricles drop, the brain just moves away from the skull, and you get the subdural. So yeah, the programmable is really the best way to manage that. Again, probably not needed in everybody, but in this group, probably more likely than not.
As you appreciate, we see very less incidents of communicating hydrocephalus in the attenuated, the intellectually intact patients. But from your perspective, when somebody with a intact cognition, what would be some of the early signs they would report to us? Is it headaches? Because I think of headaches as being, if you don't have headaches, the chance of having increased intracranial pressure goes way down. Is that a true statement or not?
To some extent, of course, headaches have a dozen different explanations. For again, for the because if these kids are going to have hydro, it's like more chronic variety, and so they may not report symptoms. They may not report headache. They might report things like changes in vision, starting to not be as crisp, and that's just because the optic nerves are swollen. A lot of it gets to mentation and how they're perceived. The way I describe this to parents is it's like a clock just kind of winding down. It still runs, it's just getting slower,
Mhm.
and so
Interesting.
yeah, so for instance, school performance, right, or performance relative to peers starts to fall behind. At some point, yes, then the headaches will start, but it's usually very late into the course. So it can be pretty challenging, and it is. I mean, certainly for this group, again, it can be really challenging to parse out in that that particular example of sort of normal mentation, like who's getting into trouble. We just don't have good tests for it.
Yeah, it's always comes up the issue of monitoring. I sort of was listening, but I wasn't sure exactly. You can put bolts in, which are much
Mhm.
more invasive, but you were talking about another procedure that's less invasive, and the people that you showed the boy that was awake. What is that again?
Yeah, it's actually the same thing. So the what we call a bolt is really just a device that holds a fiber optic cable in the brain tissue itself, and it's that fiber optic cable, the very end of it, that actually records the squeeze or the brain pressure.
Hmm.
And so the nice thing about that, again, is you saw from the picture. I mean, you can be awake. It doesn't take long to put these in. Complications are rare. That bolt, that base bolt that holds it to the skull, makes it relatively hard to pull out. Again, these kids are strong, and they certainly have removed. Kids that have these bolts have removed them, but it's invasive, but it's a nice way if you want to document actual trended brain pressures over a day or two or three, to get some sense of, well, we think there's hydro because clinically it seems like it, but hey, the pressures are low. Does get back to that confounder of, well, if you have biggish ventricles, you may have low pressure. You may have already passed the high pressure part of your hydro. But it can be a really good adjunct. And again, unlike a spinal tap, which is a one-time event, with some things that may be related to positioning or sedation, it really gives you good trended data. We can certainly sedate kids with it, mildly sedate them if we need to make sure they're going to be safe in bed. But a lot of redirection and those kind of things, often will help. So yeah, this can be a really nice way to trend it.
Is there any? So one of the questions people just ask, how common are shunts in MPS II patients?
Yeah, I can only speak to the experience here, and it's pretty uncommon. We've got some, but it is not a very common event. I did a literature search because I figured that question would come up, and there's not really a good article on incidence of shunting and MPS. I mean, they're sort of one-off type things, but the suspicion from several articles is that the incidence of hydrocephalus, or I don't know if you want to call it compensated hydrocephalus, in this group is probably underappreciated. So, but I know our experience at UNC, we don't have many at all.
I think the word compensated is a really important concept term. They may actually, have pressure at one point, and then the brain gets damaged enough that maybe less fluid's made or whatever. There's reasons that now the pressure is not as significant, even though they paid the price for that increased pressure in the past.
Right, right.
I think that's I think that's all the questions, Scott. I thank you very much for your presentation. Excellent as always.
All right. Well, thank you very much. Thanks, everyone.